trying to go to a slideshow, but I don't know if my computer is not responding. So I'm just going to start like this.
Yeah,
So
just go ahead, please.
this is a case of an acute MI gone wrong, and lessons learned from a team-based error and a team-based approach on how we tackled it. Here are my disclosures. So this is a 74-year-old man who presented with chest pain. Was doing fine about 6 weeks ago. 6 weeks prior, started having occasional exertional chest pain, undergoes an exercise stress echocardiogram, has diffuse hypokinesis 4 days prior to this event, has severe chest pain at rest, and therefore calls an ambulance and is brought to the ER. No significant past medical or surgical history. On physical exam, he was fairly stable. Blood pressure 145/81, normal pulse ox, BMI was normal, and exam was fairly unremarkable. EKG shows some first-degree AV block, maybe some non-specific ST change, but not anything very remarkable. His labs showed mildly increased troponin. This is not the high sensitivity. This is the conventional troponin. Other labs were just significant for a slightly elevated potassium level, 5.4. He was given aspirin and diagnosed with a non-ST elevation MI and referred to cardiac cath lab. He was the last add-on case of the night, precisely something I alluded to in my last talk we shouldn't be doing in a patient like this. So he gets into the cath lab about 9:40 p.m. Case is started. He's actually a little hypertensive. Radial access is obtained. JR4 diagnostic catheter is advanced to take angiography of the RCA. RCA shows significant disease, type disease in the posterolateral branch. And I'm going to skip this angiogram. And then in a couple of minutes, GR4 removed and the patient's blood pressure starts dropping. It's 91/41. Heart rate is slightly tending to be fast. Then we keep moving and put a left catheter to look at the left main. In the meantime, patient is given phenylephrine 100 mics IV for hypotension. We take picture of the left system, and it shows very tight ostial LAD, ostial circumflex, so critical 3-vessel disease. This is another picture that shows how critical this left main equivalent kind of disease is in this patient with the STIMI 2 flow. There is downstream disease in the LAD also. Catheter disengaged from left main, blood pressure is dropping further. Again, we administer phenylephrine, and patient is now getting tachycardic. Vitals, and now he's getting bradycardic now. And so atropine is given, no change in blood pressure. An astute nurse examined the patient and looked at the face, and the patient is developing a rash. Rash on the face, neck. So we are thinking probably, it is contrast reaction. So patient is given epi, 10 mics IV, 1 in 10,000 dilution. And we decided to place an intra-aortic balloon pump. Balloon pump in place pretty quickly. But the patient still is hypotensive. Epinephrine, further doses given, no effect. And the next thing we note that the IV is infiltrated. So none of the medicines we are giving are really reaching the patient. So an attempt to place a new IV quickly made, but unsuccessful. Therefore, a femoral venous sheath is placed, venous access is obtained. Now we give epi, Benadryl, Solumedrol, famotidine, all IV, and the blood pressure starts coming up. Patient remained hemodynamically stable, admitted to coronary care unit with intra-aortic balloon pump. So basically, contrast allergy added to the medical record, surgery consulted, patient underwent 3-vessel cabbage, and discharged home on day 5 on good medical therapy and recovered nicely. So essentially, in summary, this was an honest elevation MI. We shouldn't be doing this case so late in the evening. Anaphylactoid reaction to contrast media. The patient did not have a full-blown anaphylaxis because there was no respiratory difficulty, but did develop distributive shock requiring vasopressors. Then the IV was infiltrated. Essentially, this case is to illuminate that it's not just the physician who is doing the case. The whole team is involved. Sometimes, if there is failure to quickly recognize certain things like allergic reaction, infiltration of a peripheral IV, then, patient can be lost pretty quickly. So a team-based approach actually helps save the life of this patient and have an unremarkable recovery after that. And I think it's important to recognize that cath lab is a team. Cath lab is not just a physician. It's not just a doctor's case. It's everybody's case, and everybody is responsible. And as long as everybody is involved, patients tend to have better outcomes as compared to if there is a less involved team in the care of the patient. Thank you very much for your attention.
Thank you, Faisal, for finishing this on time.